Thank you, ma'am. I will be talking over the next few minutes on about the surgical microscope. And a surgical microscope, if you look at the optics, this is a very simplified version of it. You have a single objective lens, and from there, the light takes two different paths through a set of tubes. So the right and left tubes have the optical elements. There is a magnification system interposed next, and that can be a zoom optics or a telescope optics, that Galilean telescope optics that is there. Then it goes through a set of prisms and goes to eyepieces where this it's adjustable in terms of IPD and things like that. So this disparity between two ends of the lens is what gives you the stereopsis, and it allows for a good stereoscopic visualization so that we can operate with a depth perception. The working distance is decided by the objective lens, and for ophthalm, in general, we have a long working distance of around 15 to 20 centimeters. That's why all the instrument handles are around this length. So if it's any more than that, it will hit the microscope itself, which is not sterile. The illuminating system must be able to evenly illuminate all parts of the surgical field we are interested in, and that would help not have any shadows and help us in our surgery. The microscope should be stable on an articulated frame balanced on it, and one should be able to adapt to a wide range of procedures. That means we need a fairly wide range of magnification. When you go for a higher magnification, your field of view or the area you see is going to come down, as also the depth of field, that is your ability to perceive the depth and the things in focus anteroposteriorly is going to come down at higher magnification as opposed to a lower magnification. Obviously, you would see things smaller, and your resolution comes down with the lower magnification. Your magnification can be a step or a zoom system. The parts of a microscope would be the optical system, illuminating system, and of course the mechanical support. Optical systems quality would decide the quality of viewing that you're going to get through the microscope. The illuminating system, typically we have a coaxial illumination that would give a good red glow and is useful for intraocular surgeries. Whenever you want to see anything inside the eye, you're peeping through a small window, you need a light source that is not casting shadows, you need coaxial illumination. Whereas on the surface, you are better off with an oblique illumination. And there's one more reason why we should tend to go for an oblique on the surface, because these light sources are quite strong, and you have a long surgery, you can actually burn the macula. So phototoxicity of the macula is known with microscope light. So whenever possible, switch out of coaxial whenever you're working outside of the globe. What I mean is, when you're doing the conjunctive also, you're outside. Only once the intraocular do you need the coaxial. The mechanical support is the one I will actually be spending time on. It is most understated part of the microscope, and the footplate is probably the most understated in this itself. The footplate is not just a set of wheels with which you can move around the microscope. Footplate is probably the heaviest part of the microscope, and it has to be heavy enough to prevent the whole microscope tipping over with the swing arm fully extended. And this, by the way, is the only thing that should be locked fully during surgery. No other parts of the microscope should be locked, and one can have some friction resistance given by those turning knobs, the essentially screws that add friction to the movement, so that you have a certain amount of non-jerky movement, but it should never be locked. You're not there for exercise, you go to the gym for that. Most OT personnel would find it convenient to lock all joints and swing arm for their convenience. Please insist otherwise, because you need the movement while you're doing the surgery. The articulated arm typically has got two joints. There is one above the footplate and one more joints, and a pivot onto which the microscope itself, so that you can rotate the microscope finely. This allows you to move it around on the XY plane quite a bit. And the centerpiece that is there is a swing arm with a counterweight at the other end. And all of these have got friction locks, and these should not be locked for surgery. They should be relatively free for movement during surgery. One thing that most of us are unaware of is how to balance the microscope. You have a knob at the back end of the swing arm with a plus and minus on it, and this turn is turned to increase the leverage of the counterweight. There's a huge counterweight in here which is balancing this microscope's up and down movement like a seesaw. You do not want to drop the microscope onto the patient, so this has to be adjusted perfectly. So what you need to do is to gently push the microscope down or up. If it's accelerating, it is not balanced. You turn the knob either way and find out where it is balancing. The plus side adds to the counterweight, the minus side decreases the counterweight leverage, but it doesn't matter which side. You turn one way, it's getting worse, you turn the other way. That's all. And finally, the microscope should not be freely moving off, and when you push it in one way, it should stop after a small movement. It should not be accelerating in that direction, up or down. All of you have seen this picture pertaining to the mobile. It is also true of the microscope. Your head tilted forward puts a lot of strain on the neck, and that's not good. So most microscopes have got tiltable eyepieces. Adjust it so that you are practically looking straight while you're looking through the microscope, and not keep it like something like this where you have to bend down and look downwards. Your neck will eventually give up if you keep looking down for long durations like for surgery. If you're going and buying a microscope with a fixed eyepiece, there are two options. One is a 90-degree eyepiece and one is a 45-degree one. The 45 may look good, but 90 is what you should go for if you're bothered about your neck. Always center the XY motor. When you push the centering button, both the XY and the focus up down usually centers. Some the microscopes do not have this centering, so there is a marking here, two triangles facing the apex towards the center of it. The marker should be right there in the middle of those when you start surgery, because once you started surgery, you need the full range of movement possible from the motors as you press the foot pedal. IPD and refraction have to be adjusted for. It's always best if you're wearing spectacles, wear spectacles with your distance correction in place and use the eyepieces at 0 diopter rather than keep changing it and taking off your glasses. It's just like driving. If you've learned to drive with shoes, it's much more convenient, but some people have learned to drive with barefoot, and it is a bit of a hassle. Anyway, if after that you check focus one eye at a time, and if it's different, check if the eyepieces are fully pushed in. One may be pulled out a little bit or unscrewed a little bit, so they may be at two different planes. That's the first thing to check. If that's not, there's something wrong with the optical elements in the eyepiece, get it serviced, but in the meantime, you can adjust the diopter knob and focus one eye at a time. But in between, look in the distance. It's very easy to accommodate while you're doing this. So in between, keep staring off at the wall and then look back and see if it's okay. Adjusting the IPD, it's best to do it with both eyes open. Widen the IPD till there are two circles seen. Slowly bring the eyepieces close together till you see one fully illuminated, complete circular field. There should be no shadows in that circle. And this is seen with both eyes open. Look away in the distance to make sure you're not accommodating. Check again. And microscope optics are for distance vision, and even though when things are near your eye, you tend to accommodate, and to resist that, you have to look away and look back into the microscope. I have seen people trying to do this by closing one eye at a time, but when you do that, when you're adjusting for IPD, you are actually doing a cover test on yourself. Your foreas will break. We may have intermittent divergent squints that are not cosmetically apparent, and all these would break. It is not physiological. Once you start operating, things are different, and it's going to cause asthenopia or eye strain. It's difficult not to accommodate. So as you're doing this also, in between, take a peep in the distance once in a way to make sure that you are not accommodating and inducing a convergence. So to go through again, you would see initially two circles which are illuminated when it's too far apart. As you come closer, you start seeing the side of the tube on the middle, and then you have something like this. This is a shadowy area. Then you land up at the endpoint where it's a fully illuminated, complete circular field. And when it's too close together, you would see the side, the outer sides of the tube, and you need to go back that way. Microscope is just one of the many components that are involved in microsurgery. To be comfortable with microsurgery, you need to pay attention to a few more critical areas. One, you should be comfortable. Your back should be relaxed and straight. You should not position yourself with a bend in your back or overstretched, because once you start your surgery, you're not thinking about your back, you're concentrating on surgery. At the end of the surgery is when you're going to get all your spasms. You should be able to reach the foot pedals easily, and it shouldn't have to stretch. So if you're too tall, you push the foot pedal away from you. If your legs are not reaching it, you can even ask for a footstool to be under the foot pedals. Your neck should be comfortably positioned. I already told you should be looking straight ahead and not down or up. So when you're sitting at the head under a microscope, you're much closer to the head of the patient, and your microscope is practically straight down like this. But if you're operating on the temporal side, as we do for our temporal phaco is typically temporal now, you need to tilt the microscope so that your back is still straight. If I had this position here, my head would be somewhere here, which means I'll have to have a bend like this, and end of the surgery, I'll have difficulty getting up again from the chair because my back is in spasm. So you need to tilt the microscope when needed, and as and when required. All these adjustments need to be done. The foot pedal switches can be configured different. This is not a pre-configured thing. You can configure this switch to be the same as this switch and things like that. So always check your foot pedal before you start your surgery. You typically have a toggle switch like this for focus, one side going up, one side going down, but sometimes you configure it so that up is here and down is here. And this one has got a zoom and focus as toggle, and illumination switches are there on this. So you have to figure out what only switch that's going to be constant is your XY. It's a joystick like thing. You position your foot pedal so that your knee doesn't hit the table and you're not stretching to reach the foot pedal before you start the surgery. After it, all changes are going to be irritating to you. To achieve all this, you need a chair that can be adjusted up, down, a table that can be adjusted up, down, and of course, a microscope that can be adjusted up, down. A combination of all these positioning can accommodate any surgeon of any height. And once the surgery starts, we concentrate on the surgery. And by the end of the surgery, otherwise, your old sports injury that was a strain in the back or some joint is going to act up as a spasm, and you may not be able to get up from the table. At least when you're older, that's going to happen. Why am I emphasizing this? Because your health in the future will affect your professional life, not just your life. It's easy to do one case crouch down as we do in PGs. When you're learning, you're doing one case in a day. But we are planning on a career where we are doing longer, complex cases, depending on a specialty. If you're a VR surgeon or an oculoplastic surgeon, sometimes surgeries take 3-4 hours. Or if you're a cataract surgeon, you're planning to do many cases. Again, you're going to take hours sitting there in that chair and operating. And all these would contribute to disc problems. I'm not talking about papillary, I'm talking about intervertebral disc here. And that can stop your surgeries altogether at a premature age than what you had planned for. So almost all movements in ophthalmic surgery are what you call pill rolling movements or finger grip. Basically, only your finger is moving. The fine muscles of the fingers are all that's involved in the actual surgical step. For this to be controlled, your wrist and everything above has to be rock steady and that is going to contribute to your control in surgery. So find and use wrist supports wherever possible. You can use the patient's forehead, the zygoma. You rest your wrist there and move your fingers. And most headpieces of tables come with a wrist support ring, which the OT staff would conveniently hide away in a cupboard, especially if you're sitting at the head end and operating. This is handy. It would come in the way if you're operating on the temporal side, so we may have to remove it also for that. But if you're sitting at the head end, use the wrist support that comes with all the OT tables. Whatever is handy, you try to put your wrist down so that you're steady from wrist up so that your fingers can move perfectly. Also, the axial muscles have to be relaxed for your wrists to be steady. You cannot allow them to tire and start tremoring, and your surgery is going to be difficult. So your starting posture is very important for the rest of the surgery. Thank you. That's all I plan to talk about.